pulmonary anomalies, and congenital bronchopulmonary malformation. Congenital thoracic malformation comprises a heterogeneous group of airway and pulmonary parenchyma abnormalities. They are a rare group of lesions, 2% of congenital malformations, although they may be associated with fetal or neonatal morbidity and mortality. Currently, prenatal management focuses on identifying those cases that are associated with increased perinatal morbidity and mortality and that could benefit from prenatal treatment. The study of the fetal thorax is not complex and is summarized in this slide. We must study the length, shape, and disposition of the ribs, which must exceed half of the thoracic perimeter. We will have to confirm that the lungs are homogeneous with adequate echogenicity. We will also establish that the heart position is normal and therefore there is no significant mediastinal displacement. And finally, that the position and curvature of the two diaphragms is correct. Most of the times, the thoracopulmonary pathology will be detected because the heart is displaced and the lungs are not homogeneous, as in the bronchopulmonary malformations, congenital diaphragmatic hernias and hydrothorax, which constitutes 90% of the thoracopulmonary pathology. There will be a smaller percentage of anomalies that will be harder to detect. Congenital thoracic or bronchopulmonary malformation comprises a group of abnormalities. Currently, it is recommended to use this term, the congenital thoracic or bronchopulmonary malformation, instead of congenital cystadenomatoid malformation or bronchopulmonary sequestration, since, as will be explained later, there are lesions that combine characteristics of both. We will justify why is it better to use this term and not the one of congenital adenomatoid malformation or bronchopulmonary sequestration. This group of abnormalities occurs due to an insult that occurs in the early stages of bronchopulmonary development. The congenital adenomatoid malformation is the result of an abnormal development of the terminal bronchioles in the pseudoglandular phase of development at week 7 of gestation. There will be an unregulated overgrowth and consequently a suppression of alveolar growth. A hamartomatose or dysplastic lesion due to failure in the normal maturation process of the bronchioles will be considered. For the bronchopulmonary sequestration, the etiology is not clear. It is a malformation in which there is an area of the lung tissue that is not functioning properly since it is irrigated from systemic vessels. Is it, as its name indicates, a sequestration lung of the pulmonary circulation? In the last years, different classifications have been proposed to describe this group of malformations. Regarding cystic adenomatoid malformation, it is well known that there is type 1, in which the lesion with a single or multiple cyst or of more than 2 cm in diameter, which is called the macrocystic chem, or the cystic adenomatoid malformation type 2, is the one with multiple cysts less than 2 cm in diameter and with solid areas. And then we have the cystic adenomatoid malformation type 3, is one with solid appearance lesions with cysts less than 0.5 cm in diameter. It is now accepted that the final classification of this group of malformations should be based on the histopathological study of the lesions, and that the study of it in fetal life should be descriptive. We should describe the ultrasound point of view in order to establish the prognosis and optimize perinatal management. Regarding bronchopulmonary sequestration, 2 types can be distinguished. The intralobar, which represents 90% of cases, located in a pulmonary lobe and surrounded by healthy lung tissue. It is typically located in the posterior basal segment of the left lower lobe and has no visceral pleura. Extralobar bronchopulmonary sequestration corresponds to 10% of cases and is located outside the lung and covered by its own visceral pleura. It is located in the thorax, typically below the left lower lobe, although it can be found in the abdomen 5% of cases, usually in the upper left retroperitoneal area. This table summarizes the characteristics that make it possible to differentiate the group of bronchopulmonary malformations. The cystic adenomatoid malformation is located in any lobe, whereas the bronchopulmonary sequestration is typically located in the left lower lobe. The cystic adenomatoid malformation connects with the airway or the trachobronchial tree, and the cystic adenomatoid malformation has cyst in the majority of cases visible by ultrasound, and the bronchopulmonary sequestration does not. Finally, the cystic adenomatoid malformation presents a pulmonary vascularization and the sequestration a systemic one. However, we cannot always make the distinction, as 40% of bronchopulmonary malformations have mixed characteristics. As we can see in the video on the left, there is a hyperechogenic lesion located in the lower lobe of the left lung, which is located in the inferior position in which small cysts are distinguished. So it seems to correspond to a cystic adenomatoid malformation. However, when applying color Doppler, as we can see on the video on the right, a vessel is identified that comes from the thoracic aorta and irrigates the lesion, characteristic of bronchopulmonary sequestration. Therefore, this corresponds to a hybrid cystic adenomatoid malformation and bronchopulmonary sequestration. In addition, these lesions are frequently associated with other bronchial lesions, and it is now accepted that congenital bronchopulmonary malformation have a common ethiopathogenic origin and that the generic term should be used. Our objectives in this diagnosis of a congenital bronchopulmonary malformation will therefore be make a detailed and ultrasound description of the lesion, rule out the presence of associated anomalies, set the prognosis, and establish the need for fetal therapy. In this direction, the European Respiratory Society states that we must make a description of the ultrasound findings without adding embryological or pathological speculation about what we're seeing. As we have said, it is recommended to use the generic term congenital thoracic or bronchopulmonary malformation. The slide summarizes the ultrasound aspects to be detailed. Laterality of lung injury, left or right. Location in the lung, upper, middle or lower lobe. Establish if the lesion is predominantly solid or has cyst. In the presence of cyst, we should detail size, wall thickness, and content. Presence or absence of nutrient vessel by color Doppler evaluation. Dilation of the airway, existence of bronchogram. Presence of hydrothorax, displacement of the mediastinum. In addition, the upper airway and the rest of healthy pulmonary parenchyma. Let's see some examples. Left unilateral hyperechogenic lesion, mostly solid, bilobe cyst of approximately 2 cm, with significant mediastinal displacement, since the heart is situated in the right hemithorax and the cardiothoracic angle is practically zero. In addition, there is some diaphragmatic flattening, seen in the middle portion. In this case, no irrigation from the aorta was identified. There is no hydrothorax. The healthy lung was not visible at this time. Although the right lung is compressed because of mediastinal displacement and is visible, it presents normal characteristics. In the video below, however, we see a much smaller lesion located in the lower posterior lower left lung, therefore in the lower lobe. It's hyperechogenic, although the echogenicity is not as high as in the previous cases. There are no visible cysts in the ultrasound, and there is no mediastinal displacement. The heart is in its usual location. Non-vascularization from the aorta was detected. This is a similar lesion, hyperechogenic, lower left lobe, solid, without significant mediastinal displacement. However, when applying color Doppler, we visualize a nutritional artery that comes from the aorta. Artery feeding descending thoracic aorta, but that can come from the infradiaphragmatic aortic level, so it is important to make swabs that include the entire aorta and use different projections that cover the anterior and lateral wall of the aorta. The longitudinal and coronal sections are usually those that allow to identify the nutritional vessel. This is important to take into account when evaluating an injury and analyze whether it has a feeding vessel or not. In this case, The healthy lung is distinguished very well in the left, anterior and superior hemithorax, which corresponds to the upper lobe of the left lung. We should remember that the inferior lobe in the two lungs is posterior to the upper lobe in the left lung, and to the middle and upper lobes in the right. The upper lobes are best identified at the high mediastinal level in the 3 vessel plus trachea section, which is very useful for assessing the upper lobes of the lungs. In this video, we see a right mass that seems independent from the right lung. There is a large hydrothorax and significant mediastinal displacement. The heart is completely displaced. We see vascularization coming from the thoracic aorta, a coated red vessel that enters the lesion. The left lung looks compressed but of normal characteristics, and the longitudinal section allows us to identify that it exists, an extrapulmonary lesion corresponding to the lesion irrigated by the aorta, and a second intrapulmonary lesion adjacent to the rest of the healthy pulmonary parenchyma, corresponding to another lesion at the intrapulmonary level. Once the congenital bronchopulmonary malformation has been identified and described, a study protocol must be carried out to rule out the presence of associated anomalies. A detailed anatomical study should be performed, including echocardiography and fetal neurosonography, in order to identify associated anomalies. The probability of identifying other malformations is between 15 to 20%, and it is classically considered that the risk is higher when diagnosing an extralobar bronchopulmonary sequestration. The study of the heart is basic to the diagnosis of this malformation, not only to rule out the presence of malformation, but also to evaluate the impact of the malformation on the fetal circulation, the impact of the mediastinal displacement on the systemic venous return. Although the association of congenital bronchopulmonary malformation with chromosomal abnormalities is low, the possibility of performing an invasive test for karyotype should be assessed, mainly in the presence of associated anomaly. Similar to congenital diaphragmatic hernia, the use of pulmonary MRI may be considered useful to confirm the ultrasound findings in those centers with less experience in the evaluation of lung lesions, as well as to estimate the volume of the lesion and the remaining pulmonary parenchyma, and to evaluate other associated respiratory anomalies, such as possible dilations of the airway. The next step is to establish the prognosis, basically establishing the risk of heart failure and hydrops and the risk of pulmonary hypoplasia. The main prognostic factor, therefore, is the size of the lesion and the degree of mediastinal displacement. It is considered that in general the causes of hydrops is mechanical due to the displacement of the heart and the veins of the systemic venous return, although in cases with a systemic irrigation, there may be an associated hyperdynamic component. The natural history of congenital bronchopulmonary malformation is widely known from numerous studies confirming what is illustrated in these 3 videos, that corresponds to the same case in different gestational ages, that the half of the cases of the lesions decrease in size spontaneously in 3rd trimester of gestation, which seems to be related to the process of pulmonary maturation that occurs during gestation. According to the above, and although many lesions significantly reduce their size, it is recommended to carry out serial surveillance in all cases, assessing the mass size and the presence of significant mediastinal displacement, to detect those cases with higher risk of cardiac failure and hydrops. Most prenatal ultrasound protocols state that the follow-up should be done every 2 to 4 weeks till the 28 to 30 weeks, and shall include amniotic fluid volume assessment, cardiac function study, and cervical length measurement. In 2002, it is proposed to calculate the cystic adenomatoid malformation volume ratio as a prognostic parameter to be used in the diagnosis of a congenital bronchopulmonary malformation. The cystic adenomatoid malformation volume ratio calculation is obtained with the following formula: longitudinal diameter by anterior-posterior diameter by transverse diameter, all these by 0.52 divided into a cephalic circumference. This will give us a number. The congenital bronchopulmonary malformation group with a cystic adenomatoid malformation volume ratio of more than 1.6 constitutes the group at highest risk of heart failure and hydrops. The cystic adenomatoid malformation volume ratio also seems to correlate with the presence of postnatal respiratory morbidity and the need for surgical intervention. It is a ratio described in the literature and that will quantitatively allow to know the risk and to follow up the lesion, added to the presence or not of significant mediastinal displacement. The last point is to establish the need for fetal therapy. It is widely accepted that fetal therapy should be reserved for those cases in which there are signs of heart failure and hydrops, since they are cases that accumulate a high perinatal mortality. We do not have prospective studies that evaluate and compare the different therapeutic tools available. The data is based on retrospective series and case reports and are therefore limited by the number of cases. The slide shows the treatments available at the moment. Let's discuss some specific aspects of each of them. Corticosteroids, following the standard regimen for pulmonary maturation, have been associated with rapid regression of the lesion in some cases of bronchopulmonary malformation. It will be the first option to evaluate before the presence of hydrops, while carrying out other therapeutic options. The case that we show corresponds to a huge bronchopulmonary lesion with a great mediastinal displacement and associated ascites that debuted at 22 weeks of gestation. In this case, corticoids were administered following the standard pulmonary maturation pattern, without evidence of response, which evolved to stillbirth before being able to propose other therapeutic options. The thoracoamniotic shunt will be an option in those lesions that are associated with macrocyst or hydrothorax. As shown in the lower left video, there is a macroscopic lesion with a giant size that conditions a hydrops at the expenses of subcutaneous edema and marked ascites. The video on the right shows the procedure of the shunt placement. The previous fetoscopic vision allows to demonstrate, in this case, how there is connection between the different cysts. In this case, the shunt managed to decrease the size of the lesion and to reverse the shunt. In recent years, several series have been reported and accumulated around 20 cases in which it is shown that laser ablation of the feeding vessel is a technically possible option and has shown, for the moment, very good results, with regression of hydrops and resolution of the lesion in the fetal stage, and without need of treatment in the postnatal stage. This data should be confirmed with more cases, but laser ablation could be a potentially curative treatment in cases associated with hydrops. The left video corresponds to a case of high suspicion of bronchopulmonary sequestration with a feeding vessel that we accomplished to make fetal therapy and with a good outcomes, as we can see in the video of the right, with a great reduction of the size, with ultrasound images of necrosis and the reduction of the size due to ischemia. This was a case that was treated in Mexico by Rogelio Cruz and nowadays had evolved well, without necessity of postnatal therapy. Finally, there are also reported cases that have responded to sclerotherapy, performed with alcoholic substances such as etanolamine. This option will be the candidate in those solid or microcystic lesions. It is important to emphasize the prenatal treatment at the moment should be reserved for those cases with signs of heart failure and hydrops, which are the ones that accumulate higher rates of associated perinatal mortality, since, except for the corticosteroids, with a standard regimen, also present associated risks. Finally, we will talk about bronchial atresia, which may be associated with bronchopulmonary malformation and also constitutes one of the pathologies in which we should make the differential diagnosis. We're going to show a case. We see a large left lung lesion with great displacement of the heart, no cyst, and nor feeding vessel are identified, but we see a tubular hypoechoic lesion corresponding to a bronchial image. Right bronchial dilation that follows the path of the bronchus, and which is visible by accumulation of the mucus inside. The appearance is very similar to a solid bronchopulmonary malformation. It is a very characteristic image that cannot be ignored. The MRI allows us to confirm that it was a bronchial atresia. In this case, and due to the overgrowth of the lesion and the presence of signs of hydrops, parents were asked to perform a fetoscopy to identify the level of the bronchial lesion and to establish if it was possible to unblock the bronchus. In this video, you can see the entrance of the fetoscope through the vocal cords and the trachea, which is normal. The left bronchus is permeable, and the right, the presence of a membranous type obstruction that can be opened with laser, with exit of the excretions retained distally, is visualized at the proximal level. In this case, the fetoscopy allows to confirm the normality of the trachea and to diagnose the obstruction due to the membranous tissue. By destructing this membrane, we treated this case, which evolved well prenatally and postnatally. What is the postnatal evolution in this group of malformations? Generally speaking, the delivery should be made at a third level center, in those cases in which there is a significant mediastinal displacement. In those cases in which the mass is very large or there is a suspicion of associated pulmonary hypoplasia, the delivery should be planned in a multidisciplinary way, and the implementation of an exit procedure should ensure the airway in some specific cases should be evaluated. The exit technique ex utero intrapartent treatment will be explained in detail in the specific class. In those cases not associated with hydrops, a vaginal delivery can be performed postnatally, and if the neonate is asymptomatic, expectant management and outpatient management are considered in both cases, with surgical treatment being deferred to a later stage. It is generally accepted to propose surgical resection electively if the lesion is visible, using imaging techniques around the year of life to avoid future respiratory infections and the potential risk of degeneration of the dysplasic tissue. Elective surgery also allows for a thoracoscopy approach, a technique more difficult to apply if there are secondary adhesions due to respiratory infections. As a summary, the congenital bronchopulmonary anomalies constitute an anomaly that is associated in 15 to 20% of cases to other anomalies. Global mortality of this pathology is situated between 5 to 10% of cases, and when having hydrops, the mortality reaches 70 to 80%. The main prognosis factor is the size of the lesion and therefore the mediastinal displacement, which will establish the risk of hydrops. The prenatal treatment should be proposed to those cases of cardiac failure or hydrops. For those large masses with mediastinal displacement, it is important to plan the delivery. In these cases, the neonatal mortality related to pulmonary hypoplasia or hydrops can be of 20 to 30% of cases. For the rest of cases, it is important to establish that the prognosis of congenital bronchopulmonary malformation is good, and in the majority of cases, the expectant management could be carried out, and to have an elective resection at the first year of life. Thank you.